Thank you, Carlene. Good morning, everyone. I'm Janeska Roman, and I'm thrilled to be moderating our Data and Action panel discussion. Often, as public health professionals, we encounter questions like, what does health equity look like? Can we measure it? Or can we only identify gaps and disparities? So today, we are honored to have three leading public health experts with us who are working to answer these very questions. Our esteemed panel will share real-life examples of how public health data is being used to drive action for equity. But first, before I introduce our panelists, I wanted to provide an overview of what our time together is going to look like. So we're going to start off with a series of presentations from our panelists on their field of work, and then we're going to open it up for Q&A. And as a reminder, if you have questions during any of the presentations, please do use the Q&A function rather than the chat. The Q&A feature is located at the bottom of the screen. And if you have a specific question for one of our panelists, please indicate that in your question. And we'll try and leave as much time as possible to get to as many questions as we can. So with that, let's meet our experts. So it gives me great pleasure to introduce our panelists. So first, we'll hear from Dr. Hafsatu Diop, the inaugural Assistant Commissioner of Health Equity at the Massachusetts Department of Public Health, or MDPH. Prior to this position, Dr. Diop served as the Director of the Division of Maternal and Child Health Research and Analysis at MDPH. Dr. Diop is also a founding member of the Perinatal Neonatal Quality Improvement Network, the statewide perinatal quality collaborative for Massachusetts, and has served as the co-PI of the Massachusetts Maternal Mortality and Morbidity Review Committee for 19 years. Dr. Diop will discuss how the department's initiatives to monitor and report maternal mortality and morbidity data are driving statewide policy and programmatic action to reduce racial inequities and rates of severe maternal morbidity. Next, we'll hear from Dr. Amy Shea, President and CEO of the Health Foundation of Central Massachusetts, which is a health conversion foundation based in the heart of the Commonwealth. The foundation's mission is to improve the health of those who live or work in Central Mass with a focus on vulnerable populations and unmet needs. Dr. Shea joined the foundation in 2016 and plays a leading role in its grant-making and advocacy efforts aimed at improving health and promoting health equity. Dr. Shea will speak to the many ways in which the Health Foundation has leveraged its position as a funder to support efforts to shape public health policy, particularly as it relates to safe drinking water in communities that depend upon private wells. And last, but certainly not least, Sarita Hudson, Senior Director of Strategy and Development at the Public Health Institute of Western Mass. Sarita brings over 25 years of experience managing programs, developing coalitions, and building community capacity on issues including environmental health, climate action and resilience, sexual violence prevention, and women's rights. She currently directs the Healthy Air Network, Pioneer Valley Asthma Coalition, the Springfield Healthy Homes Collaborative, and the 413 Cares Online Community Resource Database Initiative. And Sarita will discuss how the Public Health Institute's work to monitor and report on air quality in gateway cities in Western Mass, and how that work is being used to guide community and systems level change. So welcome, and thank you all for being with us today. And now, without further delay, I'm going to turn it over to Dr. Diop.
Can you share the slides? I'm sorry, I can't see the slides. Thank you. Good morning, everyone. Thank you for this opportunity to share examples of our data to action around maternal mortality and severe maternal morbidity. I want to say thank you to Dr. Bisola Ojikutu for nicely setting the stage for us this morning. Your talk was very inspiring. Next slide, please. So I wanted to start with this pyramid to show the spectrum of maternal morbidity. At the top of the pyramid is maternal mortality, which is a sentinel event. used globally to monitor maternal health and the general quality of reproductive health care. Maternal death is viewed as the tip of the iceberg in terms of adverse outcomes and accounts only for a small fraction of the overall burden of poor maternal health. In Massachusetts in 2020, there were 37 pregnancy-associated deaths, and of those, there were 7 that were pregnancy-related as deemed by the Maternal Mortality Review Committee, which translates to a ratio of 10.4 per 100,000 live births, which is more than twice lower than the US rate of 23.8 per 100,000 live births. However, for every maternal death, there are about 100 episodes of severe maternal morbidity affecting more than 50,000 women in the United States. And in Massachusetts in 2021, there were approximately 117 severe maternal morbidity events per 100,000 deliveries. Next slide, please. Severe maternal morbidity is defined by the CDC as unexpected outcomes of labor and delivery, including life-threatening conditions that can result in significant short or long-term consequences to a person's health. SMM rates are increasing in the US and in Massachusetts. In Massachusetts, the SMM rate among all birthing people almost doubled in the last decade, going from 52 per 10,000 deliveries in 2011 to 104 per 10,000 deliveries in 2020, which is an average annual increase of 8.9%. Next slide, please. When we look at the data over time, what we can see here is that Black non-Hispanic birthing people consistently demonstrated the highest rates of inequities, increasing an average of 10% each year. In 2011, the gap between SMM rates for Black and white birthing people was twofold. By 2020, the SMM rate for Black non-Hispanic birthing people was 2.5 times higher than that of white non-Hispanic, which is a 25% increase in the gap over time, and was something that Dr. Bisola just mentioned in her presentation. Next slide. What have we been doing in response to this maternal health crisis in Massachusetts? We are taking a multi-pronged approach, including policy, clinical care, healthcare systems, and community mobilizations. On the policy side, the Racial Inequity in Maternal Health Commission was established by a legislative act signed by Governor Baker in 2020 under Chapter 348 of the Acts of 2020, an act to reduce inequities in maternal health. While this was unprecedented, it could not have been timelier given everything we knew about inequities and how the COVID pandemic spotlighted those inequities for us. The commission was tasked with seeking out steps to address inequities in maternal health and provide guidance and advice to the governor, the general court, and the Secretary of Health and Human Services, and to produce and file a report with the legislator that would include a comprehensive list of actionable recommendations to reduce or eliminate inequities in maternal mortality and severe maternal morbidity in Massachusetts. Next slide, please. So what have we done? On the clinical care side of things, with funding from HRSA, we are implementing remote blood pressure monitoring programs across the state, which are currently being piloted at Bay State Medical Center and Brigham and Women's Hospital, following implementation at BMC earlier, to improve awareness and obstetric warning signs for patients with hypertensive disorders. Hypertensive disorders of pregnancy, including hypertension, gestational hypertension, and preeclampsia, eclampsia and preeclampsia, complicate approximately 10% of all pregnancies. Complications from hypertension are a leading cause of severe maternal morbidity and postpartum readmissions. Almost half of the people with preeclampsia in pregnancy remain hypertensive at 1 year postpartum. So this is extremely important and necessary, as more than half of maternal deaths occur during the postpartum period, which is defined as up to a year after delivery. In Massachusetts, 35% of pregnancy-associated deaths with medical causes have documented hypertensive disorders, and Black non-Hispanic have the highest percentage of death due to a medical cause at 70.6%, and the highest percent of documented hypertension on the birth and death certificate at 47%. So remote blood pressure monitoring will help these patients. We are working with MassHealth to explore ways in which they can provide coverage for remote blood pressure monitoring programs across the states. Next slide, please. On the quality improvement side of things, through collaboration with PNQUIN, the Perinatal Neonatal Quality Improvement Network, we have implemented patient safety bundles, including the hypertension, hemorrhage, and hemorrhage bundle, and just launched the equity bundle in 22 hospitals to reduce the overall rates of SMM and the gaps between Black and white. DPH has also provided funding for the Speak Up Against Racism training offered by the Institute for Perinatal Quality Improvement. We have trained over 500 providers across 36 birthing hospitals to dismantle racism, provide respectful care that is equitable and high quality, and eliminate perinatal inequities in Massachusetts. Next slide. At the systems level, in collaboration with the Betsy Lehman Center and the state PQC, the PNQUIN, we are working on the implementation of the levels of maternal care using a slightly modified version of the levels of care assessment tool provided by the CDC. One of the unique features of our survey is the addition of the Massachusetts equity-focused questions to the CDC levels of maternal care tool. These questions include the following. Does your hospital provide implicit bias and anti-racism training for physicians, nurses, and staff? Does your hospital provide education on peripartum racial and ethnic disparities? And does your hospital have a dedicated system or process for patients and families and or for staff to report discrimination, racism, and bias, and addressing the social determinants of health? To date, we have established and convened a multidisciplinary implementation steering committee comprised of 40 members representing 23 organizations to develop a plan to implement levels of maternal care in Massachusetts. Next slide. Finally, we have established a statewide maternal health task force, which is comprised of 48 members representing 30 different organizations, including maternal health providers, people with lived experience, state agencies such as MassHealth, DCF, DAG's office, community-based coalitions and organizations, research and data organizations, quality improvement network, faculty from university hospitals and medical centers, and nonprofit organizations. The task force meets once a month, and we are working with the members to develop a statewide strategic plan to improve maternal health. Next slide. Thank you for the opportunity to present this information today. With that, I'd like to introduce our next speaker, Dr. Amy Shea.
Thank you for that great presentation and warm introduction. I'm so pleased to be with you today and to share some of our work leveraging data for action when it comes to safe drinking water in Massachusetts. Thank you to MPHA for this opportunity and for your incredible leadership on so many critical public health issues of the day. The foundation has been a proud member and partner for many years. I'm also a member of the Health Equity Compact, and I'm thrilled that there have been so many references to the Compact already today, and I hope many of you will learn more about the Compact and our work to advance health equity here in Massachusetts. Next slide. So by way of introduction, the Health Foundation of Central Mass is a health conversion foundation, as you heard mentioned earlier. We were launched in 1999 following the sale of a non-for-profit HMO to a for-profit company, and the proceeds from that sale were set aside to benefit the community in perpetuity. Our mission is to improve the health of those who live or work in Central Massachusetts with a focus on unmet needs and vulnerable populations. Our service area spans 81 cities and towns in the center of the state, and over our nearly 25-year history, we have invested over $54 million to 228 unique organizations throughout Central Mass and also across the state. Within our Central Mass region, we serve communities like the city of Worcester, which is the second largest city in New England with a population of 207,000, and also very small rural communities like the town of Warwick with a population of 780. We're unique among funders in that we don't name issues and we define health very broadly. We look to community leaders to identify the most pressing issues of the day and to propose strategies to address those issues. This approach has enabled us to fund projects in a multitude of issue areas, including oral health, mental health, upstream social determinants of health like economic development, education, and housing and homelessness. And we work together with our community-based organizations to develop collaborative and innovative strategies to address these issues. And so I'm immensely grateful to RCAP Solutions for raising awareness of contaminated drinking water in private wells in Massachusetts and for bringing this to our attention. Next slide, please. An estimated 500,000 Massachusetts residents rely on private wells for drinking water, and yet they lack adequate protections to ensure that their private well water is safe to consume, despite the fact that Article 97 of the Massachusetts State Constitution guarantees a right to clean water. Residents in urban and suburban areas have access to public water systems, which are routinely tested for potential contaminants as required by federal and state regulations. Yet we leave it up to individual homeowners and local boards of health, especially in smaller rural communities, to determine whether private well water is safe to consume. You see here in this map in green are the communities in which 60% or more of the residents rely on private wells. So there's a large concentration in central and western Massachusetts, but you also see private wells across the state. Next slide, please. So there are state and federal drinking water regulations that are aimed at ensuring safe drinking water, and yet they explicitly exclude private wells. Here in Massachusetts, the authority to regulate private wells currently rests with the local boards of health, which are comprised of elected volunteers who have varying degrees of technical expertise about drinking water, given the many health issues that boards of health oversee. There are 351 cities and towns across the Commonwealth of Massachusetts, and there are 351 individual boards of health. Under this current patchwork system of local regulations, some municipalities have very strong drinking water protections, while others have outdated protections. And some do not even know if they have private well regulations. So I have to pause and give a shout out to MPHA and its incredible advocacy work around the SAFE 2.0 Act, which is very much related to this work as well. That act would dramatically strengthen our essential local public health infrastructure and would provide local boards of health some additional resources and training, which could help address drinking water as well. Next slide, please. So I wanted to share some photos of actual private wells. These are photos from field work conducted by our grantee RCAP Solutions. These are actual drinking water sources that Massachusetts residents are currently relying on. You'll see some very old construction, debris from animals and insects, poor protection from the elements. This is the reality for some Massachusetts residents in this day and age. Next slide, please. And so in partnership with RCAP Solutions, RCAP conducted over 500 tests of private wells across the state, starting first in the north central area of Massachusetts, but then really expanding to many different parts of the state. And that testing found that nearly 1/3 of the private wells tested had levels of naturally occurring contaminants like arsenic, E. coli, radon, and uranium exceeding state drinking water standards and/or suggesting health risks. These results would be unacceptable for a public water system, yet somehow they persist for private wells. As a state, we regulate public water systems, yet not private wells. We regulate the wastewater leaving a home through the Title V Environmental Code for septic systems, yet we do not regulate the drinking water entering a home and being consumed. Next slide, please. So RCAP Solutions, in addition to the testing of water quality, also conducted some homeowner surveys to understand what homeowners think about drinking water quality. They actually found that the majority of households conduct well assessment and water quality testing infrequently. Oftentimes in these smaller rural communities, there's the perception that because residents live in a quiet, bucolic country setting, that the air must be clean, that the water must be clean, when in fact that is not always the case. They also found that when residents discover that their water is contaminated, they are willing to make repairs to ensure that their water quality is safe. Next slide, please. This work was happening alongside some of the work Mass DEP was conducting to test PFAS in private wells across the state. So several years ago, the legislature funded a pilot program to enable this free testing across the state. And Mass DEP found that about 5% of the private wells tested across the state had levels of PFAS-6 exceeding the state public drinking water standards for PFAS-6. The federal EPA has recently announced new, more stringent standards for PFAS. Under those new standards, 15% of those private wells tested would have levels of PFAS exceeding that new standard. Next slide, please. So in addition to those data points from actual water quality tests of private wells, we felt it would be important to complement those data points with a statewide poll to measure public sentiment on this issue. So we worked with Massing Polling Group to conduct a statewide poll, which showed very strong support among Massachusetts residents that all residents should have access to safe drinking water, and that state government should play a role in ensuring that all residents have safe drinking water. There's a link to the actual poll results. I don't have time to go into all the details, but some really great results there demonstrating very strong support for this issue and also for legislation that has been filed. So next slide, please. So in partnership with our lead sponsors, Senator Eldridge, Representative Sina, and Representative Pignatelli from different parts of the state, we have worked on a piece of legislation that would enable Mass DEP to develop minimum drinking water standards for private wells. As I mentioned, currently that authority lies with local boards of health. It also includes an important financial assistance provision that would help low-income homeowners with the cost of remediating contaminated wells. So the Joint Committee on Environment and Natural Resources had a hearing at the end of September, and we're hoping that the committee will report the bill favorably out of committee so that it can proceed through the legislative process. Next slide, please. We've been working hard on raising awareness of this issue. So here are just some highlights of the media coverage that we've received, including a very supportive Boston Globe editorial just a couple weeks ago. Next slide. And finally, we are continuing to build momentum and raise awareness of this issue. There's an urgency to this moment, and there's a window of opportunity with the alignment of legislation, data from many different sources, as I've shared today, public support, and the backing of many diverse organizations across Massachusetts, including MPHA. Thank you, MPHA. I hope this presentation today compels you to take action regardless of where you live and what your drinking water source is. We need your help in getting this across the finish line. There was a time when regulation of public water systems was piecemeal and inadequate, but then the Federal Safe Drinking Water Act was passed by Congress in 1974, and it set rigorous requirements for states to meet. That was about 50 years ago, and yet our system for private wells has not caught up yet. And I don't think any of us in this virtual room expect that private wells will continue to be unregulated 50 years from now. So I hope we can work together to address this inequity soon. So with that, I will turn it over to Sarita Hudson next. Thank you.
Good morning, everybody. Thank you so much to MPHA for the honor of speaking with all of you today. I'm really proud to be on this panel with such wonderful presentations and with this charge to address data to action. So I'm here today from the Public Health Institute of Western Mass. Our vision is that everybody in our region has what they need to live healthy lives. And so our focus is on working with those communities who are most impacted, our Black and Brown communities in particular when it comes to asthma. I've been working on the Pioneer Valley Asthma Coalition for over 10 years. And this work on healthy air comes out of the community effort and the community needs that have been expressed over that time. We have been working on these inequities when it comes to asthma with healthy home strategies, working with schools, working with community health workers and with clinicians. So now we are turning with this project, we have been able to turn our focus to really address what is in the air. So that has been our project. I just want to point out that we don't do anything alone. So you can see there are a lot of logos there, and we'll talk a little bit more. Out in Western Mass, we look for who are the people that we can work with. I'm going to try to go to the next slide, and if you could just move to the next slide because I don't see where to shift it. Thank you. So the Healthy Air Network. This is a website platform. So we have a number of air sensors, the purple air sensors and air use sensors that are tracking particulate matter and ozone in our region. And this website shows every dot corresponds to one of those air sensors. And it shows what is in real time, what is the air quality. It shows also weather and pollen, other data that our resident advisors have recommended that we add to that listing. This platform is maintained by Yale University's School of Public Health, Dr. Crystal Pollitt and Dr. Dong Gao, and they are busy working behind the scenes, calibrating those air sensors so that we can get research quality data on this platform. Next slide. So again, here's the list of our collaborative partners. So we are doing this in collaboration with Yale, with the City of Springfield, the City of Holyoke, Green Springfield. I'm going to say they're all their names because they're so important. Hitchcock Center, the Westfield Resident advocating for themselves: Earthwatch, U.S. Forest Service, the Asthma Coalition, Live Well Springfield, and the Massachusetts Asthma Action Partnership. It is really important that we think in terms of collaboration and that we are bringing in folks who are interested in climate resilience, in urban forestry, in other education, in other air quality issues, in healthy eating, active living, and other things to make healthy communities. We also have a resident advisory board that guides our work, and they've been recruited from different climate, healthcare, community groups. Next slide. So I want to show you a picture on the next slide of our resident advisors. So we are just really proud. This resident advisor model was developed by other staff people with Live Well Springfield, and in particular is being led now by Samantha Hamilton, our Director of Coalition Building and Community Engagement. And so our goal is in these projects that we are developing community capacity, that we're going to the community, asking what are their concerns, what is the information they need, and supporting them to be the transformational leaders in the community. We want them to be the ones deciding on this project going forward. And as you can see, these are some of the reasons that they're involved. Next slide, please. So as I said, we really are working on capacity building for our community residents so that they feel ready and to participate in these discussions. So we've had, these are some of the ones that we've had already, and our Data to Action is our next one upcoming in February. So these are really great events. We bring together all of our resident advisors from Live Well Springfield, from all of our climate resilience, our housing, the Transforming Communities Initiative, our age-friendly initiative, so that we can really work, build capacity across different issues and across different topics. And we do these capacity building efforts in collaboration with the other organizations that are working with us. So it's with our research and evaluation team, it's with our policy advocacy director, it's with Wayfinders and Hitchcock Center and ReGreen. So we're bringing our different organizations and using this collaboration to really build capacity of our community residents. Next slide. And the other part of our work is to bring this information out to the community. So we're lucky to have as a partner the Hitchcock Center for the Environment, and they just received a great grant from the Environmental Protection Agency. So they'll be to sustain our work for 3 more years. And you can see this is Dan Butterworth, who developed a model to a demonstration of how the air sensors work that we can bring out to the community. And we have a video, and that's Francesca Bermudez, who is our project coordinator. And she and Dan just did a project with one of our resident advisors work at the Mass Audubon Youth Climate Summit. So we are trying to bring this as demonstration so that we're doing some of the citizen science work. And there's a new demo that they're working on that they did for the youth about how to build an air filter. So this one, I'll talk a little bit more about that as also demonstrating how you can use a DIY air cleaner using a box fan and a MERV 13 filter. So trying to make this an accessible solution to the community. Next slide. So what have we learned in our data? So air pollution. So everybody has seen the impacts from the wildfire smoke. And so this is a picture of it. And then if we go to the next slide, you can see what it looked like on our platform. So everything was red. And there were a few green and yellow dots. Those are the places to be then. And it shows just the guidance that we give, as well as helping you understand what this looks like in our region. Next slide. So this is the back end data. We got this from Dr. Pollitt, and it shows you just how, if you look at, this was from June, you can see where the air quality generally is. And then, some very nice days along there from June 4th to June 5th. And then boom, the wildfire smoke and how it impacted just different places. And so we also see how Boston is, but you can see that in Western Mass, with our valley, which is one of the concerns, is living in the Pioneer Valley, how is that air quality, the smoke collecting and staying in the valley? Next slide. So here's another version of that same data. Next slide. And so here, what was our response? So we were getting press calls, but we also got the city of Northampton asking us, what is the guidance to give folks, the school districts, parents. So there was a lot of interest, and they were coming. We were giving out different support around it, including the information on the air cleaners, which is for individuals, but also just what is the information that local organizations need. And using our website as a resource. Next slide. So our next work on this project is understanding the root causes and looking at solutions. So we are collaborating with urban forestry to address the heat islands. That addresses the ozone issues in our region. This healing tree, I just want to point that out, that was developed by our resident advisors at our health equity training. So they're thinking in terms of solutions. So we'll be turning our attention to public transit and transportation issues, to energy efficiency and clean energy to reduce emissions as we look in the future. We are also working with the Massachusetts Asthma Action Partnership, and they will be working with three additional great gateway communities to add to our network. So I think I'm at time. So here's our contact information. If you're interested in learning more, please feel free to contact us. Thank you. I think I'm turning over to Janeska.
Awesome. Thank you, Sarita. And thank you again to all of our panelists. I'm sure that got y'all thinking. And if you haven't already, please use the Q&A function to put your questions into the Q&A. I'd love to start off our questions and discussion with a question for Dr. Diop. You spoke to the many approaches that the state is currently taking to address inequities in maternal morbidity and mortality. I guess, could you speak a little bit about how you see the future of maternal healthcare policies and clinical programs evolving or even expanding in the next couple of years?
Thank you so much for the question. There is background noise behind me. I'm so sorry. I apologize for that. I hope it's not, you're not hearing it. It's filtered through. So, as I mentioned, that in order to address maternal health, you need to take a multi-pronged approach. And Dr. Ojikutu also spoke about that in terms of collaboration, partnerships, and everything that is needed. Because when we think about maternal health, first of all, I'd like to say that anything that is related to severe maternal morbidity, the 20 conditions that make up severe maternal morbidity, for the most part, are preventable. But they do include clinical factors, provider factors, and policy factors. Traditionally, we've blamed the patient, particularly Black patients, for any complication they have or even for dying. The argument being that they come into care sicker, they're overweight, they're obese, they're older, but and all of that is to say that they're not in the best conditions when they seek care. But the truth is, that's not an individual problem. It's a societal problem. It's a structural problem. And whether or not people have access to food, clean water, insurance, or access to healthcare, these are policy and structural decisions. So when we think about how to address them, we have to really go at the root of the cause. And policies and structures are the best way to address systemic problems, not the individual level. And again, this is something that Dr. Ojikutu alluded to. Tackling these issues at the individual level is not going to solve the problem. We need to address them at the systems level to have a larger and sustainable impact. And I'm going to stop right there because I'm sure there are other questions.
Thank you, Dr. Job, for like underscoring the fact that it's not a people problem, right? It's a policy and systems level failure. And like to really get at the root, we need multi-pronged interventions that like get at the root of these policy and system failure. So thank you, Dr. Job. I now want to turn to Amy, Dr. Amy Shea. I have a question here. You know, as we look ahead to some of the emerging, what are some of the emerging challenges or opportunities that you foresee in addressing inequities in drinking water policy? And how do you anticipate that the foundation its role will like evolve to kind of meet these challenges and meet these needs?
Thank you for that great question. I think one of our biggest challenges is raising awareness of this issue and kind of highlighting the urgency of action. There are so many complex issues to tackle, including the ones that have been discussed today. And yet this is one where there is a very simple path forward. And that is really kind of brought together through the bill that I mentioned. I think philanthropy, also government, you know, we have a rural blind spot. There is so much attention focused on the urban areas in Massachusetts, so much attention focused on Boston and the greater Boston area, that we really need to work hard to address regional inequities. And so for us, I think one of our biggest challenges is just making sure that this makes it to the priority list of key decision makers in the State House and elsewhere, and that they can enact some of the easy steps, the low-hanging fruit that would make a big difference in this area.
Thank you, Dr. Shea. Sarita, I have my next question is for you. What advice would you give to other communities or regions across the state or even in New England that are wanting to implement like a similar air quality monitoring collaborative or program? Are there any key lessons learned or best practices that you can share with folks?
So I guess the first place is start with collaboration. Find those folks in your community, those other organizations that are out there who are interested. You know, our work, when I first started the Asthma Coalition 10 years ago, we did a project with Arise for Social Justice trying to do air monitoring. And we had this, like, I think it was like a 50-pound air monitor that we put behind to test at schools, to test the air quality, and tried to get that data. And now we're working with Yale School of Public Health, and we have these low-cost sensors. They're much easier to put out there and displace to place. And then we have Yale School of Public Health who's helping us with that data. So that's one example, but it's all of those other organizations. It's Regreen, it's Hitchcock, it's the city of Springfield and city of Holyoke, who are helping us do the maintenance on the sensors. So it really is finding your collaboration and then talking to the residents about what are they interested in learning. And that model, I feel like I'm repeating some of the stuff that Visala talked about earlier, but it really is getting community residents involved and committing to that process of working with the residents. That we have learned it's not just a one and done. It is a process over time, developing leadership, capacity building. I'm hopeful one of those folks will be in my position and out here speaking to you all in future. That was my idea when I first got this, was I'd bring in one of them when I got this request, because they are the spokespeople for this work.
Thank you, Sarita. like collaboration is key, and and to move interventions and policies forward, we need to follow the lead of community, right? Because they're experts like in their neighborhoods. So thank you for highlighting that. The next question that we have from our Q&A is for all panelists. So what is one of the biggest challenges that you've come across in using data from your projects to move folks to action? Not to put anyone on the spot, but maybe we can start with Sarita, and then we can kind of like popcorn in between panelists.
Sure. I think that one of the pieces is if we look at air pollution, or we look at air quality, or we look at asthma, it's not just one thing. It's multifactorial. It's all of these different pieces that are connected. And so it's a lot about understanding and trying to connect all these different pieces of data. So I think that's why I'm saying it is a journey over time and learning and going back and saying, well, how does that connect up? So I think that is the learning, I would say, is that it's a commitment to time, to really thinking back and saying, did I explain that well? And asking, is this data making sense? And understanding that iterative process. And that's why we're doing the data to action capacity building. We've been in this journey, but we need to go deeper. We need to work harder on this and listen to the residents and see what it is that they need to make this make sense for their lives, and to bring in their expertise, their lived experience.
I'm happy to jump in next. I think one of our biggest challenges is kind of overcoming misperceptions and misinformation. Especially because a lot of the decision makers are not necessarily private well owners. They do not have constituents that rely on private wells. So this, the idea of having a private well for your home and needing to test it is sort of a foreign concept. So I think providing as much information as they need from a variety of perspectives, I think that's why for us, conducting the statewide poll has been very helpful to demonstrate that broad public support for this issue. And then addressing questions that they have about the cost to homeowners. We have polled and spoken to individual homeowners to get a better sense of the cost, whether it's a burden or not. I think as more and more residents are kind of pushed out of the urban core because of the housing costs and finding themselves in suburban and rural areas, we need to ensure that these residents have the knowledge and tools and regulations they need to ensure that they have safe drinking water.
So I can add to the conversation, and I have a couple of challenges that I wanted to lift up. One is making sure that you represent all populations. And sometimes that's hard because the numbers are too small. When I think about American Indians, sometimes they're not represented in the data we have because of confidentiality and privacy issues. We're required to suppress those data. And figuring out the way we can best represent the needs of those smaller populations remains a challenge. The second one is related to lacking some data related to reviewing, for example, maternal mortality and pregnancy-associated death. We do not have all the data the community needs to make recommendations, and we are pursuing legislation. We are trying to amend an existing legislation for the maternal mortality review to make sure that we have access to all the data we need. The third one is related to the legal challenges in accessing some data, recognizing that each data source is collected under a very specific type of regulation. For example, some are FERPA, regulated by FERPA, others are regulated by HIPAA, and depending on, when it's substance use, there are federal mandates such as 42 CFR Part 2 that limit access. So how do we go around getting the authority needed to collect all the data together and link them is still a challenge. we made progress with the establishment of the public health data warehouse, which was authorized through legislation. So we are still kind of struggling with those pieces. The last one is involving communities when we are doing primary data collection to make sure that we are collecting the right data, allowing them to have a say in what needs to be collected. For the most part, like I said, the data sources are mandated by CDC, the federal, the state legislation or regs, and the populations, the communities don't have a lot to say about it. And we need to change and shift that paradigm. And it also speaks to empowering the communities, making sure they're at the table when we're having this conversation in terms of what we collect, what we analyze, and then the results going back to the communities. They need to tell us if it reflects what they know and what they want to know. So those are a few challenges, but we are trying to address them with more community engagement.
Wow, thank you, Dr. Job, Dr. Shea, and Sarita for speaking to the many ways in which you're overcoming challenges to collecting and reporting data, and just how integral it is to have community at the table, kind of driving that work, driving the types of data that we're collecting, and also shaping the initiatives to address the issues that we're seeing across the state. Unfortunately, we're at time, so please join me in thanking all of our panelists for sharing their time and their expertise with us, and for providing us with real-life models of how we can apply a health equity lens when collecting, analyzing, and reporting on data to improve public health. So thank you all.